Good morning. My name is Stanley Dube. I'm from SAP here in Johannesburg. With a colleague of mine, Sanjay, we are going to help facilitate this session with a number of other colleagues that will help with the facilitation as we go through. So this session, we are going to go through how supply chain data can actually fuel the van. And that's what we're going to go through today. And let's just get to our intro. Okay, let's switch it on first. All right, so in this session, we are going to look to discuss how data, supply chain data collected at different facilities can help organizations to run efficiently. And the focus is primarily on the collection of the data and upward transmission to then enable companies to, or organizations to make the right decisions based on the data that would have been collected. In this session, we are going to look for you as participants to actually do most of the talking, do most of the discussions in terms of the outputs that we're looking to get. So we have two items where we're going to look for you to stand up and actually move to one of the areas that we have for you to have a discussion with your colleagues, and we will note down some of the items that you would have discussed. In terms of our schedule, just a brief intro, then our first activity will then be looking at defining the different consumption and distribution facilities that are within the value chain of healthcare. And this we'll do as a large group just to define what these facilities are and classify them, give them some attributes that actually define them. Then the second exercise that we will do is then to look at what data is actually required. So we're looking at now saying what data needs to be collected, how is it going to be transmitted for the van to be able to provide the insights that are required. Then right at the end, we will look for each of the groups to actually do a wrap-up and a presentation of what their findings were from the second session. Right. So let's start. I've got a picture on the board. So that's actually a picture there. Any ideas what that picture represents? Any guesses? So there are 6 blocks that are there. So let's take it a bit further. So I've increased the resolution. I've increased the amount of data that is within that picture. Still, any ideas what that picture? It's a warehouse. Okay, all right. Yeah, good guess. Yeah. Pardon? Segmentation. You're saying all the blocks. Okay, all right. Let's move one forward. Yeah, good. Yeah. It is indeed the Mona Lisa. And as we move further on, as we add more data, it becomes clearer to say it is indeed the Mona Lisa. Even with that, we don't have all the data, but we can actually tell that it is indeed the Mona Lisa. So the idea being that as we increase the resolution, as we increase the data points that are being gathered, we can actually get a clearer picture of what's happening within the supply chain. Without this data being collected, you at times don't have a view of what's actually going on. And if you don't get the data in time, you might end up with a picture that is not actually representative of what's going on. So We believe there is need to increase those data points to actually feed the van to be able to give you as organizations, as entities, the ability to manage the process. If we link this to the van, and I think we've started already, right at the bottom, there's need to collect data, and data coming from different facilities. It could be the inventory levels. It could be looking at what has been dispensed. It could be different forms of information that is coming in, temperatures possibly, or even the number of births within a specific region. All of this information collected, processed in terms of enabling visualization and the analytics of the information, then enabling organizations to make the decisions that they need to make. So you most likely see the visualizations. Some of this data, you might not actually see it. It is being collected. You only see the visualizations right at the end of the process. Moving on, so the first activity that we'll do, just to recap, we're going to look to identify different types of storage, distribution, and dispensing facilities. We're then going to look to define some of the characteristics, some of the attributes of these facilities, then possibly put them into some logical groups in terms of the facilities. So that's the first one. Then a follow-up in terms of the first step. In small groups, we'll then look to determine what data is actually required at each of these facilities. How is that data then collected? And what data is required? Then possibly start looking at what are the different ways of enabling the collection of the data, come up with a guideline possibly. And we will facilitate each of these sessions. The output for this session, we intend that when you leave, you've got some insight in terms of what data is required, how the data can be collected, and possibly ways of starting to look at how do you enable this within the organizations that you are operating in. So we are looking to provide some insight for you, for us also, in terms of what's going on.
So in this group, we talked about a mobile outreach center, and the attributes of this in general was that it was a bicycle, it was one person, they had a dumb phone, and they had limited cellular access, no data, and only SMS capability, SMS and phone calls. This person was responsible for inventory management. They were responsible for planning their own route. They were responsible for, let's say, keeping records of the drugs they administered, and they were responsible for administering it. So this bicycle is probably some guy on a bike with the cooler on the back. Yeah, and some backpack or something like that with some essential medicines as well. Okay, so no power either, no Wi-Fi, no TV, no bed. So if we talk about the types of data that we think that this person needs, or when they go to refill their inventory on their bicycle, what the facility would need to refill, we talked about having some sort of way to estimate demand, whether it be based on populations they know in the villages they're going to with the previous administrations and next doses, for example, or some sort of understanding of the village they're going to and the population there, which also indicates they know where they're going, the destination, how far away it is, maybe the temperature and weather conditions of this route to make sure that they can take it there without the product expiring in the cooler. And some things that we would like to know, maybe if there's any political or social activity going on in the path that may interrupt their route. Some of the other data they would want is when they are there administering the drugs, they would record the bursts, they would record how many drugs are administered, how many doses they used, how many doses they brought versus how many they used. And when they returned back, they would also have some wastage that they would bring back to the facility for destruction. And so we debated a little bit about how this would be done, because it's very intriguing that SMS is available to us, and we all know there's some tools out there to record a SKU and a quantity. But ultimately, because we said we have these needs of data related to the birth and the vaccinations, this HMIS type data, we can't really transfer that information over SMS very efficiently. So ultimately, the conclusion of the team was that the bicycle rider would take out a registry, record the information, bring it back to a facility like a community center, aggregate the data, tally the data, and record it in whichever system that community center is using, whether it be a paper-based registry, a tablet, or computer-based LMIS, HMIS type system.
Community centers really, we're talking about community health volunteers. This is based on feedback from DRC Congo and Senegal. So we're really talking home to home, where a community health volunteer would go to somebody's home, or vice versa, somebody would come to the community health worker's home. So consequently, I'm just going to say CHV from now on. The CHV is responsible for their own transport to the health centers, or potentially they would come out. All manner of transportation is used, especially in Congo. Boats, bikes, everything, right? I think it's probably similar for Senegal. Obviously, cellular coverage and electricity are big problems. The mobile device ranges from feature phones or super simple cell phones to smartphones, but the smartphones are few and far between. The characteristics or attributes, the CHVs see patients, and they will dispense medication. It's a bit of a hub and spoke model carried to the extreme, right? So if you think about the health centers as being a hub, the community health workers would be spokes, but then they become their own hubs to spokes of patients, if that makes sense. The good news is CHVs can typically read and write, and we're talking rural context mostly. Do we want to do this too, this section? Okay, the needs are pretty straightforward. We're only talking about managing about 20 commodities. Typically, your typical medical commodities like paracetamol, antimalarials, family planning, ARVs. Vaccines are not managed at all by CHVs. So they would typically keep track of the name, the village, the kind of malady or the condition, and they also might provide some rapid diagnostics. Only malaria, right? I think that's great. It would be great for these CHVs to have some sort of case management system so they would know who to follow up with. There are some technological solutions out there that run on smartphones, so therefore they would want smartphone, data plan, and some way to recharge it. Those are all related to data needs.
When I say district store, how we define it is we're really talking about the tier above the health facility, which is ultimately serving the patient. So it could be anywhere between a 3 to 5 tier supply chain, but we're talking about the tier right above the health facility. In a lot of the countries that we were sort of referencing, that might be a district store with, not necessarily dedicated logistics HR, maybe limited storage space, limited or inconsistent power supply, potentially inconsistent or limited stock or inventory management practices. So just to give you kind of a sense of that. In terms of where we landed, I think what we kind of envisioned as our end state was having almost a retail-like inventory control data visibility model where, you know, as a district store, I have visibility or assurance that the level above me has sufficient stock for my needs based on my min and max levels for my own store. I also have visibility into the stores below me, and I can see their min and max thresholds as well as where they are on those thresholds at a given time. But that's where we sort of struggled with system design. You know, that's a helpful system if, say, I'm responsible for replenishing them. But if the health facility has to come to me, that becomes more complicated. So in addition to that, we talked about needing to understand things like when collection happens, what the reorder cycle is like. Obviously, you need historical consumption as an input to min and max levels. So we were kind of all over the place. We talked about how in the ideal, something like that would be an electronic system where we're automating a lot of those data flows. But we've also seen examples of where that can work even informally or simply with Excel tools and SMS-based reporting. So in a lot of supply chains, that's, you know, a good starting mechanism. We didn't talk a lot about how I sort of get replenished or how I replenish my own store, but that would, obviously, if we had more time, that'd be something we'd want to think through a bit more.
So what we discussed about some of the challenges related to people. So when I say people, it actually in turn actually put lot of impact on the productivity, is because more productivity is more profit making. So from that angle, the frequent brain drain. So whatever experienced people that actually joins the hospital, okay, and they when they leave, certainly they have to be replaced by somebody who is new. So the brain drain is one of the challenges, and that in fact it's putting a lot of pressure and getting the productivity or the profit margins down for these private hospitals. Data collection and reporting, because there are a lot of government regulations for which the private facilities, they need to submit the reports to the government, okay, and since they are not actually earning any revenue out of those services, okay, so they consider that as a loss, that why I should be doing that, okay, without making any money out of it. So that is again one of the challenges between government and private facilities. Some of the important attributes which we discussed about is certainly these facilities are for making profits. Mostly these facilities have presence in urban areas. Okay, yes, they do have presence in rural areas as well, but not to the extent of the public health. They certainly have power available, internet available in most of the cases, almost 80 to 90% of the cases. And these facilities are ready to invest. As long as they see the profit anywhere, they are ready to invest into whatever that is required. Some of the data needs for these facilities is the patient records, because they want to analyze the patient's data so that how they can do or improve their services, with the help of which they can make more revenue. So electronic medical records of the patient, so which actually gives all the information about the patient, is something which they are interested in. Something around the data around public health, that is actually the want, is because currently these private facilities, they don't have access to the products, the vaccines which are released by the government. So if they can get this particular information, that will be really good for them. Next is about in the need, that is services provided in public health. Okay, so whatever services they are providing as per the government regulation, okay, they want to keep a track of that time, is because that time is that way non-productive for them, not generating any revenue for them. And they need to have the business insights, is because how my business is doing, how I can attract more patients to my hospital so that I can make more profits, is something which they want to look at. In the want, actually this data around public health is something which they really want from the government, if the government can share that data with them. And even they want access to inventory information, is because whatever consumables they need day in day out. Okay, they want to they want to know that which warehouse has the enough stock and how quickly they can get, just to ensure that they are getting the stuff whenever that is needed, rather than maintaining the inventory, so that they can cut down the inventory cost and increase the profit margins. How they can achieve it? Since these are profit making organizations and they are ready to invest, so we feel that certainly they are looking for some kind of ERP solution which keeps track of everything, what is coming in, what is going in, going out, and all of that. And they can also get some HIS system to track the patient care. So that ERP is one area or one thing which they are looking at. And integration with the public health or the government systems is something also that they are looking at, so that the information can flow from government systems to the EMRs of those private facilities, and reverse as well, the information can flow out of them. So that way, that information exchange can happen, and certainly that will help provide more or better patient care for more profits. Thank you.
Okay, so that's obvious. They often will have electronic catalogs, but sometimes they don't. They would often have climate control and other what you could call GDP qualifications inside their warehouse, but sometimes they don't. They tend to have a proper amount of staff to get the job done, because their main focus is, of course, the service of delivering. Security, plus or minus, I don't remember exactly what that was. Yeah, so they might have it, they might not. One of the attributes is they often substitute products without asking or verifying with the client, so that's not really a good thing. Okay, so here we had sometimes it's good because they'll be in a preferred supplier arrangement with a manufacturer, which means that they will by default have a certain level of quality which might not be there in other cases. And also, just in general, because they serve a market, so if they're serving, for example, the donor community, they will have quality requirements aimed at the donor community which are higher, which means they have a reputation, which means that they keep up their reputation, and so on and so forth. But the type of reputation they have can change based on which market they're trying to serve, which can be very good or also very bad. Info. Oh, so this is the how. Challenges. Product lists. Sometimes they have it, sometimes they don't. Sometimes they provide it, sometimes they don't. Based also if it's paper or electronic. Data standards. So it's linked. Possibly less patient-centric. So because it's motivated on profit, which we also discussed a bit with pharmacists, but they will stock what sells. What sells might not be what's required on a prescription. If the prescription item is not there, they don't tend to be prioritizing getting it in the next shipment, so or just keeping it on stock if it's not moving. Okay, informal dispense. Oh, so this point was good because they'll split up a standard dispensing unit. Perhaps they'll give out less syringes instead of a box of 1,000. They'll sell 10, depending on the client that they have. So then we start talking about the data. So what would you need? You need all of the basic things: lead times, order cycle, delivery schedule, customer orders, all the general ones. But additionally, we would like to see information on quality level, product availability. We talked about public health, how the product fits into public health, dispensing, what are some of the effects of the product. Is it being used rationally? Is it not being used rationally? So really dispensing information that would be useful for this business to be able to provide a service level, a higher service level. So that goes into the guidance documents. So one of the other things we discussed was in procurement, if you want to procure from a specific manufacturer, it would be interesting to have data on quality checks or other validation audits have been done by other people such as whoever, WHO, MSF, somebody like that. Just so that you don't have to duplicate efforts, because the actual process of regulating a manufacturer is very in-depth and takes a long time. So you want to be sure that where you're purchasing from is from a manufacturer that's going to continue manufacturing, and also to have some transparency on whether that manufacturer can meet the demand that you're giving it over the long term. And the other thing we discussed would be it'd be nice to link with health promotion from the public health sector. If there's a wellness campaign or they're going to market type of illness. And then the how. So I think the most compelling discussion we had was just on the power of a professional association within a country to bring together all the wholesalers to even do type of self-audit, so that to be part of the association you have to do X, Y, Z, and to sort of disseminate information, best practice, and so on and so forth. So a strong associative was felt in the absence of strong regulatory body, do you want to say, to be probably the best solution.
Well, I'm Moka, and I run a technology company based in Kenya, and so maybe I might get into a little more detail, but just some context. We've been working in Kenya now for the last 6 years, and there has been a dramatic shift. When we started, 56% of the footfall was public. Right now, it's over 60% that is private. And the growing market is the private clinics that are owner-operated clinics. And so we wanted just to talk about this, in that context. Now, these are clinics that are, in essence, run by healthcare providers who work in the public facilities. So it is not, it is part of the public workforce. So a lot of the training that is done to the public workers, these are the implementers. So one might say, are they, clandestine workers? No, they are not. They are just folks who are setting up their own side business. With that, the attributes, many of them, they start with a table and a chair. Basically, you have a room where you can get approved by your local district health officer. You get approved, and you hire your friends to work for you. They will somebody will put in 2 hours in the day. Another person might give you 5 hours. Someone might work weekends. So temporary staff. They manage demand in real time. So you might say, okay, well, we know this is the season for a certain disease, and so you might, overstaff for that period. But it's hit or miss. The beauty about these guys is that they have tremendous flexibility as far as commodities and supply chain is concerned. In most cases, they are responding directly to shortages in the public facility. So the KEMSA in Kenya supplies every 90 days on the low side, but in most cases, it could go up to 6 months before the supply. During that downtime when the drugs are low in the public facility, these are the guys who are making drugs accessible to the populations. And their locations are in the villages. I mean, sometimes we hear private and we think urban. I think, in my opinion, that's a big myth. These guys are in the villages, close to the homesteads, providing services. They are the neighbors who are providing services. And so because of that flexibility, it certainly creates a certain access to, basically, because of that flexibility, they are motivated by, as any other business owner. The incentives are clear. So they tend to sort of invest progressively in their infrastructure. It's not unusual that you'd find them with a solar panel. So while the dispensary might not have, electricity, they would have electricity. While the dispensary might not have access to the internet, they would have, use their mobile phone as a hotspot. And some even provide internet in their clinics. I mean, there's one clinic that we've worked with that has, they like an internet cafe in the clinic. And let's see, they have flexible hours. In most cases, they would say they work 8 to 5, but if there's business at 9 o'clock, they're working, or they'll get a friend. And so they are very, very flexible. In terms of challenges, staff turnover is high. What does that mean practically? No systems in place. Because today is this person, next is that person, so very high staff turnover, as much as 30% turnover in some of the clinics. quality of medicines, it's a nightmare. Because basically they are buying from very last mile retailers. The van comes with it, here's a drug for the day. You're not sure where the drug is coming from. You just say, okay, I need to stock up, and you buy based on price. It's a very price sensitive market. So this is one of the areas they have no capacity to regulate. And because they are buying mostly drugs that come in containers, you can't do track and trace. You know, they buy 1,000 per the tins, they're buying those tins and stuff like that. And then no clarity inside, I guess, is the point, but you could clarify that. In terms of needs, it's a business. So they access to keep track of their finance, how much they are making, how much they are spending, zero visibility. It's almost like a household kiddie, you know, and stuff like that. Typical private business, mom and pop shop. So that really affects their ability to get credit. The healthcare sector is run on credit. If you want to get drugs from the wholesaler, you say, give me your drugs for 30 days, I'll come back and pay you. And that's how it goes up the ladder. They can't access credit. So that really limits who they can do business with in terms of quality providers. They depend on the inefficiencies in the public sector. So if, let's say, let's give an example. For example, the pediatrician is on leave in the public sector. A lot of pediatric cases might come to them. They might start seeing more pediatric cases. Or the most typical case, KEMSA supplies drugs for 30 days, every 90 days. Within 30 days, the public facility is low on stock. These guys now are the ones who are picking up the volume. But that visibility, again, they don't have. It's completely empirical. Either they heard from a colleague that this is happening and it might affect their business, and then they adjust. So access to some sort of data, you know, which shows seasonality of disease or the peaks and the, you know, ebbs and flow of data in the public facility would really help them. You know, and then access to credit, quick access to credit could really create better quality of care in the last mile if we kind of looked at it from that perspective. In terms of what they want, visibility of supply, knowing when those guys will come is very important for those guys. Basically, you might expect them to come today, they come 2 weeks after. So you can run out of paracetamol for 2 weeks because that guy doesn't come in. Or then you send somebody from, let's say, Lamu or Kakamega to the Nairobi market to go buy. So it's their big problem. They have zero visibility of when the supply would happen at that last mile. Because this is now tier 4 of the retailer. That is the really last mile guys in cars and motorbikes who are pushing drugs to them. They don't have inventory. If they cannot see it and count with their eyes, they don't know what they have in stock, you know. And so they could easily run out of tablets, you know, and so you could, later you can start somebody on 1 day of treatment of malaria because those are the 3 tablets that are left. And that starts creating very significant problems in terms of compliance at that level. In terms of how, I'm a big advocate, access to patient data is good for these guys. Theoretically, if you build a van and these guys don't have access to the van data, I think it would be a missed opportunity. Certainly, you know, a mobile app, you know, with access to common healthcare data could really help them improve their forecasting and help them make their business case while they're accessing credit or while they're thinking about how to staff, optimize their services, or what kind of training or opportunities they could think about improving on. There are a couple of success stories, to close, whereby I've seen some of these guys. There's one lady who started in the 1996. Right now, she's building her 5th hospital. So there is potential in this market here, and it's a market that's growing at 12.3%, much faster than the public sector. So I just wanted to highlight that. Thank you.
Okay, so we talked about the state hospital. I think one of the unique some of the attributes of it, it's bigger, it's got higher volume, it's typically in an urban area, and so that means it's connected to roads and infrastructure, which are nice and convenient. It also, in general, has some higher SKUs that it's managing, and so it's a little bit more complicated. They're providing, they're playing multiple roles. Typically, as a state hospital, they are providing products to patients, but also to, they may be providing products to facilities that are within the catchment area of that hospital. So those roles are kind of varying, and that may be a little harder to manage. We also talked about the uniqueness that they're managing equipment and other assets, so beds, lab equipment, other diagnostic equipment that they're having to manage and control and make sure are being maintained, which is a unique component there. And often because of the high throughput and the large amount of SKUs and disparate roles and responsibilities, we kind of made a judgment that the stores tend to be less well organized and they don't have the infrastructure, especially in a state hospital. So we talked about a number of different personas. The hospital manager at the top, and then we talked about differentiating between a storeroom manager and a stock manager, acknowledging that there is product that's flowing in a similar way that perhaps a district warehouse would be supplying facilities underneath it, that there might be a store in the hospital that is then supplying different wards within it. And so you've got your own little mini distribution network within the hospital. And then we talked about the lab tech, which has unique needs and a large number of SKUs that they're managing, and then also, we didn't quite get to it, but pharmacist. So just in general, hospital manager needs to track overall everything that's happening underneath them, a consumption of each of the different wards. They need to know forecasting, because they are probably at minimum approving what orders are being placed to be resupplied, and they have to have an understanding of budget, how much they're spending and what available funds they have available to them. The stock manager is probably the entity that is managing all of the products that are being dispersed out to each of the wards. So they need to know the consumption at each of the wards below them, and they need to have visibility into the stock that is sitting at each of those wards and that average monthly consumption. And we felt that visibility is often lacking in terms of once barcoding or some way of product verification in terms of quality of the data, because this is often a person who might be in charge of a large number of products and making sure that quality is there. Batch and expiries we talked about as well, and then they may also be playing the role of rebalancing across the different points that services are being delivered. So they may move product from one place or another, or direct that. They may have to make executive decisions about who is getting what product to in a case where they don't have enough and they're rationing. So storeroom manager, they need to know stock on hand. They may be filling out an R&R that's either sent up to the store manager, the stock manager, or to all the way up for reordering. And then also incidence of stockouts, length of those stockouts, perhaps even number of services that were missed, if we want to be even more detailed. Number of people affected. And then lab tech, we talked a little bit about the equipment uptime. We talked about product dependencies, that often to run a test you need multiple products, and if you have one of those, then you aren't able to provide your service. So having an understanding of what each of those dependencies are was really important. Sample management, they're probably getting samples again from multiple different referrals, so they've got things coming in and going out. And then in terms of what they need, again, asset management, what the frequency of maintenance of that equipment would look like, whether there's a contract associated with it, getting the results of a test back into the patient's records and notifying the patient is a data need as well, ideally, and getting that into their medical record system.
We are powered to the grid with no backup generator, although we do have maybe 5 or 6 refrigerators that are powered by solar as backup. Our vaccines are fulfilled with orders received directly from the PHC. So PHC submits orders by email and Excel and directly to the district warehouse, and then distributed out. Whereas essential medicines the demand is submitted back up from PHCs to Central, and then Central decides how to kit up all the essential medicines needed, and then it's passed through as a cross-docking operation through the district store. These facilities have 5 to 10 people. They have these cold chain technicians, stock keepers, and a manager. Most of these facilities are too small for the amount of goods that they're storing or passing through. They serve 30 to 50 PHCs. They have no labeling capabilities. Let's see, and they do stock cards for vaccines, but they do not do stock cards for essential medicines. So that's the facility and the attributes of that facility. We decided we'd have two personas. One is the stock keeper that receives goods, and then the other one is the stock keeper that ships goods. So as a stock keeper who's receiving goods into the district store, they have many needs. They want to have when the goods arrive, they want to have a shipping manifest which matches to an ASN, and the ASN is passed by email from a system. It's also passed by SMS, but that's also not preferred because of all the data that comes by SMS is because it's so frequent, it's not very valuable. You end up ignoring it, right, Paul? Yeah. Okay, we won't tell anyone. They want to know the central warehouse wants to know the quantity of goods that were received and then the ending balance and some information about maybe when some of the batches are going to expire, and then central then will validate future orders for replenishment. Also needed by the stock keeper is lot numbers, expected delivery dates, and then outside of maybe more specific supply chain transactional data, but also like to know if there's program information, different changes to medicines. They'd like to know when new products are coming so they're not just ignored when they get to the warehouse. They'd also like to know if there's any recall data, so any products that are being recalled and need to be segmented or quarantined or sent back. They'd also like to know prior to delivery what the driver name is, the driver's phone number, the types of products that are coming, the product family, etc. And if there's any special handling requirements that they need to be prepared for when that truck shows up. That information mostly today is handled by email, SMS. There is some capability because we have cellular access to have a mobile application. And then there is some discussion and probably some capability we could consider in the future to extend the WMS capability from a central warehouse. The other persona we did was a stock keeper who's shipping. So for this, there's a process where the PHC process ships the order up to this district warehouse. The district health manager validates the quantities and the quantities that are being ordered and then passes them to the stock keeper. The stock keeper only needs to know the order number, the SKU, the quantity, the location they're delivering to, and the schedule that's been agreed to on a once-a-month basis, roughly. Then they'll also create a manifest and a delivery note. This information is not passed by data, it's just done on paper, right? So one thing we didn't talk about, but maybe you can talk to really quickly, is would it be helpful for the PHC to receive a digital notification that their goods are shipped or when they're going to deliver in the future? Okay. Okay, so I'll add that. And then when we talk about essential medicines, there's also a delivery note that goes out. The 3PL in this scenario is taking invoices with them, and then when they deliver, they're capturing a proof of delivery, or you called it a goods receipt notice, and bringing that back, and then that information then is then validated, so the 3PL can be paid. Today that's all being done by paper, but that could be enabled with the 3PL through a mobile app in the future.
Okay, basically from outside we looked at the mobile clinic setup. The attributes specifically to that is that you usually make use of a vehicle like a combi or a van or whatever, and there's usually a fixed route or a schedule for that specific vehicle to go to. The electricity is usually generated either by battery power on that specific vehicle, and I don't know if they are so sophisticated like using solar at this stage, but I mean that's a possibility that can possibly be used. They have a refrigerator or a cold box on board. So for actually collecting samples if it's required, but they do basic things like maybe blood work, blood pressure, that kind of things. Then usually the staff on a vehicle like that is one nurse that will basically do the consultations, will do the package handout. So it's not a huge vehicle with a lot of staff on it. It's specifically to most rural areas where you need to bring the service nearer to the point of the actual patient. They usually operate from a primary health care level, so they will be linked to a specific primary health care facility or a clinic where they will obtain their packages for specific patients. The challenges, weather is always a challenge. It might be snowing, rain, a road might be gone, or some things of that, which will result in disruptions of your schedule. Also, the vehicle can break down, okay, which will impact on that specific service delivery. Record keeping and referrals, and your referral tracking. Okay, so obviously they see a patient, they hand over to a patient. If there's more serious medical needs, that patient needs to be referred to either a clinic or a hospital. And I think the main thing is there to actually manage that referrals to that specific facility. Stockouts usually resulting from wherever they get the stock. So today we don't have TEE, which will never happen, I hope. Then you cannot actually service that patient that's coming to your clinic. In most instances, there's only that one staff member that's actually in charge of that mobile clinic. So tomorrow I'm sick, or that staff member is sick, okay, then that mobile clinic is standing still. Temperature monitoring, as I said, some of them might have a fridge on board, some only have a cold box on board, so that gives it a challenge in terms of temperature monitoring. No computers, cell phone towers not available for cell phone coverage, that sort of things. So yeah, that's the environmental challenges. Then who's the actual people involved in this? We usually say it's the nurse, but if I refer to the nurse, it also depends on the size of that specific facility. There might be only a nurse at a facility. There might be a doctor that's roving, and there might be a pharmacist or a pharmacist assistant. But this might be one person as well, okay, that's delivering that total service at that PHC facility. Then you will have your patient, and where do you get the stock from to actually stock that specific PHC facility, so your warehouse. We've divided it up into needs, wants, and tools. So the nurse basically needs to look at the patient records, temperature monitoring. We referred here to the CCMDD process. So that's trying to decant your bigger facilities to a smaller clinic or smaller point of collection. And then your route status was one of the things that they felt was important. If you cannot go and deliver today, what are you doing? And where do you get that kind of information? Most of the tools that they use is paper-based or bin cards, stock cards, And if you are lucky, you can have a mobile that you can actually use and utilize. Then on a primary healthcare level, what is the responsibilities? So it's stock management. If this mobile is actually standing still for a few days, okay, do you have the information to actually ensure that that patient still gets serviced? They did not get their stock, so we are referring to ward-based outreach teams that will then actually collect that stock and go and deliver to a patient. Then we have the stock visibility system, which gives you insight on the actual stock holding at that specific facility. And also giving you an indication of the actual orders that's been placed on your warehouse and the delivery between these two. Expiry management also by that specific facility to ensure that stock moves that is going to expire. And yeah, that's in short the whole thing.
So the intent here was to come up with a segmentation of facilities, so different types of facilities that we have in our supply chains. These all complement facilities that we explored in the same session the hour earlier, and we'll try to find some different facilities later. And the idea being that for each one of these different types of facilities, we capture the different data needs. We'll find that some are different, some are the same, and we'll overlay that together and publish the results. This will be a plan that then you could use to help facilitate work within the countries when they're ready to create a national data strategy. You could use this to then enlist suppliers such as SAP and Crave and Navision, etc., and get RFIs back, solutions back on how do they meet your needs, how do they meet your wants for all these different types of segments. And we shouldn't expect them to come back with one solution. It should all be SMS, or it should all be mobile, or it should all be OpenLMIS, for example. It's a combination of these tools and processes and different people at these facilities that will solve these problems. So hopefully this will lead into that work and contribute for these countries.